Andrea Ciccarone from Brescia, and I'm a resident physician in infectious and tropical diseases in Italy. And I'm spending a month here in Hood School Hospital. Thank you to the Eskimit Observership program. The case I'm going to show you, it's titled Fever in a Returning Traveler, Blood Millions Matters. I wanted to begin by showing you a little bit of this photos of the cities where I grew in, where I studied in, and where I'm currently living, because they are outshined by their neighbor cities. Oh, pardon. So this is Treviso, which is the city I was born in and where I grew up. This is the main square of Treviso, and is located about 30 minutes from Venice, in the northeastern part of Italy. It's definitely outshined because also Treviso has some nice spot to use. And the main reason why it's famous overall is because of its Prosecco region, which is called Vado di Adne. And yeah, but I mean, South African wines has, yeah, they defend themselves. This is Ferrara. This is the city where I studied medicine. I lived here for about 6 years, and it's located near Bologna, which is the city that outshines her. And this is Brescia, which is the city I'm currently living in and where I'm doing my residency, which is quite an old city because it was built around the same period of Rome, and it still has some temple in it. And this is the hospital where I'm working in right now, and it's the place where the case that I'm going to tell you about took place. So, about the case. Back in 2023, in November, in my first year of residency, I got to meet this 46 years old man who was born in Senegal and who is currently living in Italy since 2013. He had no significant medical history at the time of the presentation, and he just returned from a 1-month trip in Senegal. He didn't took any prophylaxis for malaria or for other infectious diseases, and he had no pre-travel vaccinations. Approximately 10 days after his arrival in Senegal, he developed fever, a fever which lasted for about 5 days and which was treated empirically as malaria down in Senegal without any testing being performed. He came back to Italy, and 1 week after returning to Italy, he developed a severe headache with myalgia. And that's the reason why he presented himself on the 3rd of November 2023 to the emergency department of Brescia's hospital. And yeah, the clinical examination at first was quite unremarkable. The patient was afebrile. He was clinically stable. He had no clinical findings at examination. Blood tests were as well unremarkable. He had mild anemia, 13.8 of hemoglobin, a mild thrombocytopenia, 128,000 platelets per microliter, normal CRP, normal renal and liver function. Of course, as a patient who had fever during travel and came back after travel, the first thing that we wanted to place was malaria, which was negative. Both the blood smear, the antigenic test, and the PCR on blood. And because of his severe headache, he underwent a CT scan, which was unremarkable as well. Because of his symptoms and because we couldn't define what he had, he was admitted at the neurologic unit of Brescia. On day 4 upon admission, fever came back, and he had a worsening in blood tests, especially in the thrombocytopenia, which went down firstly to 60,000 platelets per microliter, and then later, a day later, platelets went down even more, down to 39,000 per microliter. He had monocytosis and increased C-reactive protein, 195 milligram per liter, which is a normal value of which should be under 5 milligram per liter. He underwent blood and urine cultures, which were negative, and he repeated the malaria testing, which was as well negative. At this point, a consultant, an infectious diseases and tropical medicine expert was requested as consultant. And do you have anything in mind if you have any kind of diseases that come from analysis?
Rhinosis. With the initial acute episode, and then fever again, recurrent with headaches as well, leptospirosis needs to be considered. I mean, there are various others that.
But I mean, Prof. Mendelssohn was quite direct because our physician wanted to do by himself a blood smear, and this is what he found out on blood smear. On the left, we have a thick blood smear, and on the right, we have a thin blood smear, which shows spirochetes. In particular, we had a diagnostic confirmation. The diagnostic confirmation was obtained through real-time PCR, which was sent to our zooprophylactic institute, and with a 99% certainty, they identified Borrelia between these 3 different species, Procedura, Plutoni, or Hispanica, which are the main cause of tick-borne relapsing fever caused by Borrelia group. It was most likely acquired in Senegal. So I'm going to talk a little bit about tick-borne relapsing fever later. I will go on the case right now. On day 5, patient began the treatment with doxycycline, 100 milligram bid. After 2 hours after the first dose, he developed high fever with chills, dyspnea, and hypotension, which is just standard jelly presentation. So he was treated with IV fluids, oxygen, paracetamol, and methylprednisolone with a rapid improvement of symptoms. Like I was telling before, the platelet count was quite low, so the lumbar puncture was deferred a little bit. So we did it when he was already under doxycycline treatment. And the CSF test showed an increased amount of cells, in particular with a 90% presence of lymphocytes, an augmented amount of protein in liquor, and with normal glucose. CSF was sent as well to the zooprophylactic institute in order to perform PCR in it, which came out negative. But because the lumbar puncture was deferred, we couldn't know if this was like a decapitated meningitis, or if the neurological symptoms were related to the spirocheteria, which is a common cause of neurological involvement during Borrelia infection. We switched the treatment, just to be overcautious, to IV ceftriaxone. Patient did well during his admission. He was discharged on day 17 without residual headache, and he completed 14 days of total treatment to the outpatient parenteral antimicrobial therapy. So let's talk a little bit about tick-borne relapsing fever. Tick-borne relapsing fever is caused by Borrelia bacteria of the relapsing fever group, which could be divided in 2 groups: the low-borne relapsing fever and the tick-borne relapsing fever. The first one is mainly represented by Borrelia recurrentis, and it's called also the epidemic form of relapsing fever, while ours is the endemic form of relapsing fever. It's mainly transmitted by ticks of the genre Ornithovorus, which are soft ticks, which usually of whom a reservoir is are rodents, and which usually bite during night, especially in houses infested by rodents, which is why we think that, which is the way we think that the patient acquired the infection. It's endemic across almost the whole world, apart from Australia. And the pathogenetic mechanism of the recurring fever is because of its antigenic variation. So you get the fever, Borrelia reproduces itself. Our immunitary system controls it. Then the Borrelia has an antigenic variation, so it can evade our immunitary system and multiplies again in order to give fever again. And this cycle usually occurs every 10 days. How do you diagnose tick-borne relapsing fever? You can do it like we did with plasma, which is a rapid and accessible test, but it is operator dependent, and it's not too much. It's not that sensitive because it requires at least 10,000 to 100,000 bacteria per milliliter. The most sensitive method to diagnose tick-borne relapsing fever is through blood PCR, which can also give you the species that cause the illness. And another method which requires equipment and expertise is the quantitative battery cohort. The serology, on the other side, it's not that useful during the diagnostic workout. It could be useful for epidemiological studies. The problem for the future is that malaria testing with the upsurging of rapid diagnostic tests and antigen tests, this could bring to a less usage of blood smear. So consequently, this could bring to an increased underdiagnosis of tick-borne relapsing fever. So with this case, I wanted to show you a case that we found out by a little bit of luck, but I mean, the first way to diagnose tick-borne relapsing fever is to suspect it, as Prof. Mendelsohn did. And a negative malaria smear can still bring some information, so it might be helpful to do a malaria smear, even if you have a PCR antigen test for malaria. And yeah, as every spirally, be prepared for a very short time. And that's it.